Hello, everyone. My name is Sergey. Um, how's it going? Today, I would like to talk to you about a serious topic that has been bothering me um, very heavily, and a lot of people that I know, and I'd like to shed some light into the what's going on. So. Basically, this is going to be a review of a medicine that I'm currently on called Abilify. Um, it is a antipsychotic medicine, generation 2. Some people say generation 3. Depends on the sources. Um, and It's really fucked up what you can learn about this stuff. And we're going to start off with this link right here. And all of my links are coming from Google Scholar. And so these are all official medical studies and like certified results that are known about this stuff. Let's start with current concepts and treatments of schizophrenia. Alright. Okay, this is what I need to read. Abstract. Schizophrenia is a debilitating mental illness which involves three groups of symptoms, i.e., positive, negative, and cognitive, and has major public health implications. According to various sources, it affects up to 1% of the population. The pathomechanism of schizophrenia is not fully understood, and current antipsychotics are characterized by severe limitations. Firstly, these treatments are efficient for about half the patients only. Secondly, they ameliorate mainly positive symptoms. Examples, hallucinations and thought disorders, which are the core of the disease. But negative, example, flat affect and social withdrawal. And cognitive, example, learning and attention disorders. Symptoms remain untreated. Thirdly, they involve severe neurological and metabolic side effects that may lead to sexual dysfunction or agranulocytosis. Clozapine. That's another medicine. It is generally agreed that the interactions of antipsychotics and various neurotransmitter receptors are responsible for their effects to treat schizophrenia symptoms. In particular, several G-protein coupled receptors, GPCRs, mainly dopamine, serotonin, and adrenaline receptors, are traditional molecular targets for antipsychotics. Comprehensive research on GPCRs resulted in the exploration of novel, important signaling mechanisms of GPCRs, which are crucial for drug discovery, intentionally non-selective multi-target compounds, allosteric, and I'd like to apologize, I do have dyslexia, this is kind of hard for me, allosteric modulators, functionally selective compounds, and receptor oligomerization. In this review we cover. Okay, so that's a summary of what schizophrenia is, right? That's all I wanted from that, just a summary. So we're going to go back and we're going to read this. Treatments for schizophrenia, a critical review of pharmacology and mechanisms of action of antipsychotic drugs. Fine, you can have my cookies. It's whatever. It's like made in the 90s or some shit. Treatments for schizophrenia, critical review of pharmacology and mechanisms. You already read that. Okay. Abstract. The treatment of schizophrenia has evolved over the past half century primarily in the context of antipsychotic drug development, although there have been significant progress resulting in the availability and use of numerous medications. These reflect three basic classes of medications: conventional, typical, atypical, and dopamine partial agonist antipsychotics, all of which, despite working by varying mechanisms of actions, act principally on dopamine systems. The way that ended was weird to me. Many of the second generation atypical and dopamine partial agonist antipsychotics are believed to offer advantages over first generation agents in the treatment of schizophrenia. However, the pharmacological properties that confer the different therapeutic effects of the new generation of antipsychotic drugs have remained elusive, and certain side effects still impact patient health and quality of life. Moreover, the efficacy of antipsychotic drugs is limited, prompting the clinical use of adjunctive pharmacy to augment the effects of treatment. Okay, I'm just going to read it all. In addition, the search for novel and non-dopamine antipsychotic drugs has not been successful to date. Although numerous developmental strategies continue to be pursued, guided by various pathophysiologic hypotheses. These articles provide a brief review and critique of the current therapeutic armamentarium for treatment of schizophrenia and drug development strategies and theories of mechanisms of action of antipsychotics, and focuses on novel targets for therapeutic agents for future drug development. Okay. These are the references. I thought this was interesting. Miyamoto S. Reminds me of Shigeru Miyamoto. And there's another one from Miyamoto S. And another one and another one. You know? I really like the stuff that they have written about this stuff. It's some doctor in Kyoto, Japan. Keep scrolling. Okay, a little faster. There's a lot of studies and references to back this up, what I just read you. And this is just proving that these are all things. I'm scrolling even faster. Oh my gosh. They just keep going. Okay, that's all I needed to read off that site. I'm sorry, my mind is messed up from this stuff, and it's really hard for me to organize my mind from this stuff. So that's all we needed to read was that. Let's go back. Okay, so now I just wanted to read those to tell you what schizophrenia is and what the treatments are. Alright? I am on a medicine that is in generic form known as aripiprazole. And I guess the brand name for it is called Abilify. And so we're going to read aripiprazole, a novel atypical antipsychotic drug with a unique and robust pharmacology. So yes, this is the most cited. There's the most citing of references to this article on this particular drug that I am on, This just says a reading list. There might have been more to this. I'm going to try to go back to this real quick. Got it. Okay, cool. Yes, see, stuff like this happens all the time. Like shit pops up, disappear. You know how it goes. Okay. Introduction. Schizophrenia is an important health issue affecting almost 1% of the population, frequently with significant social and economic implications, as patients often suffer from unemployment and are homeless. Moreover, antipsychotics prescribed to treat schizophrenia are used in bipolar affective disorder, which has a prevalence of 2.3% of the population. Consequently, about 16.5 million patients of the EU need antipsychotics on a daily basis. Oh my god. I haven't read this yet, I guess. This generates a significant healthcare cost, as central nervous system disorders are among the most costly medical conditions, and 386 billion euros annually in the EU. Current treatments of schizophrenia have significant limitations. Firstly, they are efficient for only about half the patients, enabling them independent life. Secondly, they ameliorate mainly positive symptoms, hallucinations, and thought disorders, which are the core of the disease. Ameliorate, yeah, but negative, example, flat affect and social withdrawal, and cognitive, example, learning and attention disorders, symptoms remain untreated. Thirdly, they involve severe neurological and metabolic side effects that may lead to sexual dysfunction or agranulatosis. The reason for this, okay, I think I already read this. I'm sorry. I apologize. I'll try to cut out what I've already read. They cite different parts of it in the scholar thing or whatever. The current understanding of schizophrenia is constituted by the dopaminergic hypothesis, which denotes alterations of dopamine neurotransmission in the mesolimbic system, responsible for positive symptoms, and mesocortical pathway, causing negative symptoms, complemented by the complemented by glutaminic hypothesis, which considers changes in prefrontal neuronal connectivity involving glutamatergic neurotransmission of NMDA receptor. In particular, increased presynaptic dopamine synthesis is relevant for the pathogenesis of schizophrenia. The methods of treatment of schizophrenia are classified as the first quotation, mainly dopamine D2 receptor antagonists. Second, multi-targeted antagonists with greater antagonism in serotonin 5-HT2A receptor than at dopamine D2 receptor. And third generation antipsychotics represented, example, by aripiprazole, brexpiprazole, and cariprazine. Aripiprazole is a partial dopamine D2 receptor agonist in G-alpha pathway, but it can display agonist, partial agonist, or antagonist activity at dopamine D2 receptor upon different signaling readouts. In particular, it is an antagonist or a partial agonist for beta arrestin 2 signaling pathway. As G protein coupled receptors, GPCR, are classical and well validated targets for antipsychotics. The elaboration of concepts on the nature of GPCR signaling opens novel and unexplored possibilities for more effective and safer antipsychotics. GPCR functioning is conceptualized by the tyranny complex model, which involves activation of the receptor by agonist and transmission of signal G protein. However, it was reported that many GPCR ligand display high degree of promiscuity, which is considered a drawback in GPCR-oriented drug discovery. Okay, yes, in many complex diseases, including schizophrenia, the single target drugs turned out a failure, whereas multi-target drugs are much more efficient. Clozapine has a low nanomolar affinity to several aminogenic GPCRs, which reflexes the complex pathomechanism of the disease. Another important breakthrough in the field was the discovery that a specific receptor can couple with a few G proteins and can signal independently on G proteins by occurring in an ensemble of conformations which trigger interaction with biased ligands and downstream effectors. This phenomenon is termed the functional selectivity and may lead to safer drugs thanks to selective modulation of one pathway over another one. In the field of dopamine D2 ligands and antipsychotics, it was found that many clinical useful drugs are antagonists of B-aristin recruitment. Contrarily, it is also reported that dopamine D2 receptor ligands, which are antagonists of whatever that is, pathway, and contrarily, it is also reported that dopamine D2 receptor ligands, I just read that, may display beneficial antipsychotic properties with diminished extrapyramidal unwanted effects in animal models. Allosteric modulation of GPCR has lately been a hot topic in GPCR-oriented drug discovery, as whatever that is, mode of action brings important advantages over orthoceteric drugs, better receptor or even pathway selectivity, and fewer side effects and ceiling effect, reducing the risk of overdosage. This approach has not yet been exploited for antipsychotics. However, a positive whatever that is modulator, PAM, of dopamine D2 receptor, a PAOPA, whatever that is modulators, NAMs, of dopamine D2 receptors are known as whatever that is, homocysteine and analogs. And their usefulness in schizophrenia needs to be further evaluated. Finally, targeting heterodimers of dopamine D2 receptor, which are distinct pharmacological entities, in particular that serotonin, and whatever this is, heterodimers with bivalent ligands, dimer-specific monovalent ligands, and compounds causing ligand-induced dimerization of peptides. Peptide dynamics or small molecules disrupting dimer interface may lead to better pharmaceutics with higher selectivity and tissue specificity. Among compounds Targeting these dimmers only bivalent ligands, not drug-like due to high molecular weight, are relatively easy to design. Compounds from other groups are not known either for D2 dimmers. Dimmer-specific monovalent ligands and ligands inducing dimerization, or in whole GPCR family, small molecules disrupting dimmer interface. It was only reported that peptides corresponding to the dopamine D2 receptor transmembrane regions effectively dissociated the dimmer. In this review, we cover current hypothesis of schizophrenia involving different neurotransmitter systems, discuss available treatments, and present novel concepts in schizophrenia and its treatment involving many novel mechanisms of GPCR signaling. Schizophrenia as a complex disease. I'm going to start summarizing. You know what? Fuck it. I'm going to read the whole thing. I'm sorry. This is so important to me. The dopamine hypothesis of... I know that doesn't say dopamine, but I'm going to use slang, I guess, if you want to call it that. The dopamine hypothesis of schizophrenia is the fundament of the investigation and treatment of schizophrenia. The first version of this hypothesis stressed the role of an excess of dopamine, but it was developed into an idea linking prefrontal, whatever that is, and striatal hyperdopamine, whatever, and then to the current aberrant salience hypothesis. The dopamine hypothesis of schizophrenia has proposed for the first time in 1960s when chlorpromazine was introduced as the first antipsychotic and proved to treat positive symptoms of the disease. Subsequently, discovery that amphetamine produces psychosis was another proof for a role of excessive dopamine in schizophrenia. It was thus proposed that the increased dopamine neurotransmission might be a reason of this disease. The advancement of novel antipsychotics was in accordance with the dopaminergic hypothesis of schizophrenia, as it was observed that positive symptoms of the disease can be attenuated with dopamine receptor antagonists. However, some findings contradicted this hypothesis. Example, clozapine, which is a very effective antipsychotic in patients with resistant schizophrenia, has rather lower affinity to dopamine D2 receptors. Moreover, more patients with schizophrenia have also normal level of dopamine metabolites in cerebrospinal fluid or serum. These contradictions and novel findings from PET studies led by Davis that's the 24 is a case study or something, to propose that schizophrenia involves diminished frontal and increased striatal dopaminergic neurotransmission. Moreover, they linked the positive symptoms of the disease with the striatal dopamine D2 receptor overactivation, resulting in hyperactive mesolimbic dopamine projections, while negative and cognitive symptoms result from the prefrontal cortex dopamine D1 receptor due to diminished mesocortical dopamine projections. Further reformulation of this hypothesis has been reported. Nowadays, aberrant salience hypothesis of psychosis most commonly links dopamine system with the symptoms of schizophrenia. It is based on the incentive salience hypothesis, which suggests that mesolimbic dopamine neurotransmission is crucial to the attribution of salient. That word salience, that's falling asleep for no reason. That's what they're describing there. It's crucial to the attribution of salience, which governs attention and affects decision making and functioning. The aberrant salience hypothesis assumes that the attribution of salience is disturbed by excessive dopamine firing in psychotic episode. While in healthy individuals, dopamine is responsible for mediating contextually appropriate saliences. This revised version of dopaminergic hypothesis of schizophrenia may explain some clinical and pharmacological features of the disease, i.e., why the schizophrenia patients do not develop all symptoms of psychosis at once, or why antipsychotics exert their therapeutic effects after weeks. Moreover, it can also shed new light on the side effect of diminished motivation in patients with antipsychotics medication and on the recurrence of psychosis after drug withdrawal. As mentioned above, the dopamine D2 receptor is a drug target for all drugs against schizophrenia currently present on the market. First and second generation antipsychotics are dopamine D2 receptor antagonists, while third generation drugs are partial agonists or biased ligands of the receptor. Many drugs applied to treat schizophrenia are antagonists of D2, like D2, D3, and D4 dopamine receptor subtypes. As dopamine receptors play a key role in coordination of movement, memory, and cognition, emotion and affect, and the regulation of prolactin secretion. Blockade D2-like receptors may result in side effects linked with the long-lasting antipsychotics medication. This involves Parkinsonian-like extrapyramidal symptoms, typically resulting from the application of the first-generation antipsychotics, and metabolic side effects: weight gain, hyperglycemia, increased risk of diabetes, dyslipidemia, and gynecomastia. Linked with the second generation antipsychotics in this period. There's a period there. Fuck. In this regard, there are some reports which indicate that D3 versus D2 dopamine receptor selective ligands may be an interesting alternative to treat schizophrenia. It has also been found that antagonism of dopamine D3 receptor may be partially responsible for whatever that is caused cortical dopamine and acetylcholine efflux and cognitive improvement. Importantly, selective dopamine D3 receptor antagonists are not efficient in antipsychotic animal models based. Okay, I'm going to reread that. Importantly, selective dopamine D3 receptor antagonists are not efficient in antipsychotic animal models based on D2 receptor antagonism. On the other hand, selective D3 receptor antagonists influence dopamine neurons' electrical activity in the ventral area. I think there's a summary at the bottom of this. I'm remembering now. I'm going to summarize this. I believe I read a summary at the bottom, which is, these are all the references. There's about there's 176 studies or references backing this up. Let's go back up. Okay. Con- yeah, I'm not going to read all of this. I'm sorry to waste your guys' time. Okay. Okay, current concepts and treatments for schizophrenia we did, and treatments for schizophrenia. This is the one. This is the one that I wanted to summarize, actually, I believe. Okay, I can't do that because I don't have an institution. Okay. Anyways, I'm going to skip around to make this shorter as possible. Basically, I am on this, aripiprazole, and this is the most cited study. A novel atypical antipsychotic drug with a unique and robust pharmacology. This was published in 2003. The thing I was just reading you, I think, was 2018 or something. Okay. Atypical antipsychotic drugs. I'm not gonna. I don't want to read all this. I don't want to read all this. So this is what it. Yeah. I think this is the one with the summary at the bottom. So anyways, this one here says basically all the stuff that it does good for you, apparently, or what it's good at. And these are all the references that made this. So a lot of the references here too. I apologize. I'm going to edit this, but I just had to get this out here. Results. There it is. I found it. Fuck. Results. Affinities of aripiprazole for dopamine, serotonin, and other receptors. The affinity for aripiprazole for a variety of receptors was measured by competition radio radioligand binding assays. Table 1 summarizes the affinity values and also lists the radio ligands, blah blah blah. The affinities for this. No, this is not. What is this? No thanks. Okay, fuck this. I'm trying to show you one thing. It might have been here. Nope, it's not here. This is getting ahead of me. I'm trying to find. I want to just read the quote. I can't find it right now because it messes with you with this stuff. But basically, the conclusion came that there was no. Well, for this aripiprazole, there is no proof that any class of schizophrenic drugs actually, they basically affect, the drug affects what everyone with the disease would consider the positive effects, which is seeing and hearing things that aren't there or whatever, and the only of it basically makes the bad parts worse and the parts that you kind of use as a safety mechanism if you have it non-existent. Okay. So, with that being said, and that's for all of them, all of the antipsychotics. I can't find it because I'm being fucked with. But anyways, here, we'll actually do this. Anyways, I looked up what the side effects of this stuff was, and there was only there's one thing that really upset me. And oh, here's the other part. I gotta look this up. I'm gonna tell you this first too. This is alarming. Abilify mycite. That's the name of it. I'm actually Oh, this is why I can't find it. Okay. Yeah. I can't spell that. Aripiprazole. Okay. And you guys are seeing real time what I deal with every day, basically. So, if this means anything to you, watch the whole thing, please. Um, um, Here it is. A placebo-controlled, double-blind study of the efficacy and safety of aripiprazole in patients with acute bipolar mania. All this shit that pops up. Yes. I think this is the site. Okay. This whole site basically says that it works. This is the American Journal of Psychiatry. All of this stuff here is what I was basically describing, but it's saying that it had positive effects. Okay. I think it's been removed. I think it, my hands are sweating. I can't. No, this isn't it either. I have it on my phone. I should have just looked earlier. Okay, I see what I did wrong here. Okay, I found it. That summary. I did not find it. Found it. I found it. Sorry for the cut that's going to need to go there. But that thing I was talking about earlier. Conclusions and future prospects. Although current concept and treatment of schizophrenia are based on the dopamine hypothesis of the disease, novel approaches involving new signaling mechanisms or classical drug targets on completely new targets emerge. Schizophrenia is a complex multi-factor disease, and according to the current knowledge, it does not seem very probable that all symptoms of the disease can be treated in a single target drug. Indeed, clozapine, which is used to treat resistant schizophrenia, has a nanomolar affinity to dozen of emergic GPCR. Searching for multi-target drugs. In summary, after over a century of schizophrenia treatment, significant progress has been achieved, starting from lobotomy operations through discovery of... They changed this. No, I know, it didn't change. I'm looking at the wrong article. Another cut. Okay, my mind is acting up. I'm going to give up on trying to find the exact part that I was trying to say. Basically, all you need to know is that all drugs that are used to treat schizophrenia right now get rid of the positive effects and then magnify the negative ones. That's just how they work. And there's no study that they do anything that is actually effective for you. So anyways, we're skipping ahead. I'm going to cite this. Here it is. Okay, this is Medline Plus, drug information. This website is it's a government website. It's funded by the government. It's run by the government. Read this. Okay. Where am I trying to find? Okay. First, I want to cover this. There's a version called Abilify mycite, and this is very concerning. Um, uh, the tablet. Okay, where do I start? Okay, fuck it. The tablets, just right here. The tablets contain a small sensor. This is Abilify mycite they're referencing, but there was some other stuff up here that's not coming obvious to me. But it says the tablets contain a small sensor and come with a patch, a wearable sensor that detects a signal from the tablet and a smartphone application app to display information about how you were taking the medication. The app must be downloaded on your smartphone before you start the medication. Apply the patch to the left side of your body above the lower edge of the rib cage, only when prompted by a smartphone app instructions. Do not place the patch in areas where the skin is scraped, cracked, inflamed, blah blah blah. The app reminds you to change the patch and explains how to apply and remove the patch correctly. Keep the patch on when showering, swimming, or exercising. If undergoing a magnetic resonance imaging (MRI) medical test, the powerful magnets take pictures. Remove the patch and place it with a new one as soon as possible. If the patch causes skin irritation, after you take the medication, the tablets can be detected in the body by the app within 30 minutes to 2 hours. So the problem with this is the chip is not very effective, doesn't pick up correctly usually, and it leads to basically making you take the medicine incorrectly if you actually deal with this kind of stuff. So I just wanted to tell you that. Oh, I gotta bring that back up. Okay, right here. You should know that some people who took medications such as aripiprazole developed gambling problems or other intense urges or behaviors that were compulsive or unusual for them, such as increased sexual urges or behaviors, excessive shopping, and binge eating. Call a doctor if you have intense urges to shop, eat, have sex, or gamble, or you are unable to control your behavior. Tell your family members about this risk so that they can call a doctor even if you do not realize that your gambling or any other intense urges or unusual behaviors such have become a problem. You should know that when used to treat children, it should be used as a part of a treatment program that may include counseling and special education. Be sure your children follow all of his or her doctor's therapist's instructions. Okay, I got that out of the way. Let's go back to this then. I want to read this completely. This paper details 3 case reports that suggest that pathological gambling activity may be adversely modified following treatment of psychosis and the antipsychotic aripiprazole. These reports are discussed in the context of previous observations of the potential impact of aripiprazole on impulse control and the implications such observations could have clinical practice in future research. Could have for clinical practice in future research. We already read about the D3. Okay, case study 1. Jay was referred to the clinic, age 29, and was taking aripiprazole 5 mg for treatment of paranoid schizophrenia. He reported a 12-year history of regular gambling and was gambling daily at the time of assessment. His first treatment session, he described feeling that the medication had caused an escalation in gambling and discontinued taking it. Jay managed to stay abstinent from gambling for the next 4 weeks, with the exception of the lapse. 2 weeks later, he was placed back on aripiprazole 15 mg following a relapse of psychotic symptoms, and subsequently reported the return of strong urges to gamble that he found difficult to resist. He was preoccupied with thoughts of gambling, and his gambling activity became both impulsive and involved extensive planning in obtaining funds to gamble, including the use of crime. Following discussions of his psychiatrist, Jay was changed to quetiapine 400 mg and later to solproide 600 mg. He subsequently reported a qualitative change in his gambling and with the absence of ongoing thoughts and plans to gamble. This abstinence has been maintained with Jay, who has followed up 6 years later. Okay. These must be good. These must be good. This also has changed since I've read it. Case study 2. K referred to himself to the clinic age 28 and had previously been diagnosed with schizoaffective disorder. At assessment, K described the history of gambling on fruit machines as a teenager and fixed odds betting terminals in his 20s. He would usually gamble 2 or 3 times a week, spending about half of his money, but reported a change in his gambling following a hospital admission 10 months earlier. During the admission, his medication was changed from risperidone to aripiprazole 15 mg. On leaving hospital, approximately 3 months after the prescription of aripiprazole, K described an escalation in his gambling to the extent of spending all of his money, and it being a reason to live. A reason to live. By the time he presented to the clinic, he had limited his access to money, but described spending 8 hours a day searching the internet for free gambling opportunities. Following a recommendation of his psychiatrist, his medication was changed to that. Kay reported this having a massive impact on his gambling. By treatment and 3 months later, he felt no preoccupation or compulsion to gamble and was playing only once per week. Case study 3. S self-referred to the clinic age 26 and was taking aripiprazole 15 milligrams for the treatment of schizophrenia. S had experienced one episode of psychosis in 2002 and had previously taken risperidone. S reported no history of gambling prior to starting aripiprazole in summer of 2006. In summer of 2007, he began experiencing strong urges to gamble in the form of a euphoric feeling when thinking about gambling. In the following 2 years, he incurred debts of around $25,000 on internet betting sites. S was the third individual taking aripiprazole seen since the opening of the clinic. As a consequence of the previous case, the team wrote to his psychiatrist in the community, suggesting a review of medication. Given the time since his original psychotic episode, the decision was taken to cease all medication. S attended 1 month after discontinuing aripiprazole and reported no thoughts or drive to gamble. He described an inability to reflect on his behavior when taking aripiprazole and always suspected it had induced his gambling. S completed a gambling craving scale previously adapted from the Penn alcohol craving scale. His score of 13 out of 30 at treatment start had reduced to 5 out of 30 by treatment end, indicating rare, slight urges that were mildly difficult to cope with. His abstinence from gambling has been maintained at both 3 and 6 months follow-up. To conclude, the case studies suggest further potential side effects of aripiprazole and emphasize again the need for additional research and for vigilance in its use with individuals exhibiting a history of impulse control related difficulties. Okay. With that being said, I'm going to close all this out. Originally, I was diagnosed with, so although I had a lot of extensive training to help deal with it, dyslexia runs in the family. I would probably describe that as probably like the top problem I have. But I was a number of years ago first diagnosed with bipolar, and they put me on medicine, and that didn't work. And then that was up to a schizoaffective, a possible schizoaffective diagnosis. And then from there has evolved into a paranoid schizophrenia diagnosis. And I want to say I've been on this Abilify for a total of 3 months. There was a skipped month in between, and then I was put back on it. And in that time, I've had some mental breaks, but all the time that I've been on this medicine, Abilify, and I take the injection form, so it's a slow release version that basically is in you the whole month. I've been kind of obsessed with this one game. I really like it a lot, and I played it as a kid. Um, but this stuff caused me to basically start this campaign where I was trying to save this game, which is old and archaic, right here. It's going to get deleted. And it's a good game and all, whatever. But I wasted so many hours trying to be positive and deal with the manic episode that I was in, that I made basically social media to try to raise awareness for the game, and that project failed. Um, but yeah, I'm seeing some patterns and stuff that I'm not liking, and that's basically all I have to say for today. Uh, Thank you very much. Please subscribe if you'd like to know more. I'm going to be probably studying this extensively. This has just been day 1 or 2 of the study that I've been doing. There will be updates in the future. Thank you. Have a good one, guys.